Hello, my name is Karen Schlanger, and I'm an epidemiologist at CDC's Division of STD Prevention. Today I'll be presenting on the implementation of two pilot antibiotic-resistant gonorrhea emergency tabletop exercises in Marion County, Indiana, and Champaign-Urbana, Illinois, as a strategy to enhance local, state, and federal antibiotic-resistant gonorrhea preparedness. Since the 1930s, Neisseria gonorrhoeae, the bacteria that causes gonorrhea, has developed resistance to each antibiotic class used to treat it, and currently declining cephalosporin and azithromycin susceptibility has raised concerns about the threat of untreatable gonorrhea. Responding effectively to outbreaks of antibiotic-resistant gonorrhea, or ARGC, will likely be very challenging due to challenges identifying ARGC, limited treatment options, and overall public health limitations containing the spread of any STD through partner services. Conducting emergency tabletop exercises, or TTXs, may assist local, state, and federal public health officials effectively prepare for detecting and responding to an outbreak. So the purpose of piloting the ARGC tabletop exercise in two jurisdictions was fourfold. One, enhance local, state, and federal preparedness for ARGC outbreaks that we anticipate will show up in the U.S. sometime in the near future. Two, develop, test, and improve state and local outbreak response plans and procedures by identifying gaps and areas for improvement. Three, pilot TTX materials to ultimately share with other jurisdictions that can then use them to develop their own outbreak response plans and conduct their own tabletop exercises. And fourth, to inform ARGC preparedness activities at CDC. The tabletop exercise started off as a collaboration between CDC's Division of STD Prevention and Center for Preparedness and Response. We then identified two state and local health departments interested in piloting the TTX in a local jurisdiction. We chose to partner with the Indiana State Department of Health and the Marion County Health Department in Indianapolis, both of which already participate in CDC's Strengthening the U.S. Response to Resistant Gonorrhea Project, or SURGE. As we thought it would be useful to pilot the TTX in one jurisdiction that had already built up some of this infrastructure for rapid detection and response. We were also then pleased to partner with the Illinois Department of Public Health and the Champaign-Urbana Health District. CDC then developed a draft ARGC outbreak response plan guidance document to guide jurisdictions as they developed their own ARGC outbreak response plans. This document includes information to guide the structure and content of local ARGC outbreak response plans, including considerations for thinking about things like case definition, surveillance, and ensuring capacity to identify and respond to treatment failures. And it also included considerations for response team roles and activities, treatment and testing options, communication strategies, as well as planning, outreach, and data analysis. Using this guidance, Indiana and Marion County Health Departments chose to develop one combined ARGC outbreak response plan, and the Illinois Department of Public Health and the Champaign-Urbana Health District developed their own ARGC outbreak response plans. To plan the actual TTX pilots, we use CDC Centers for Preparedness and Response's structured and well-tested TTX planning and implementation process, a process they've used across a wide variety of public health emergency scenarios. This process included defining planning team roles, meeting schedules, tasks, and timelines. And the planning team for each of the two pilots met 5 times over 4 months. The planning teams included STD and emergency management leads from each of the 4 health departments, as well as representatives from CDC. CDC also developed the hypothetical scenario that was used at the TTX, which included the local health department being notified about multiple cases of suspected GC treatment failures despite treatment with recommended therapy. CDC also developed a situation manual, which was provided to all TTX participants, facilitator slides, and a facilitator's manual. Additionally, CDC developed and conducted a 1-hour webinar for all participants to take in advance of the tabletop exercise to ensure basic ARGC knowledge across participants with very different expertise. The participating health departments in Illinois and Indiana identified all the participants, obtained upper leadership support, organized all meeting logistics, and identified local facilitators and note takers. Each of the 2 implemented TTXs were organized as 6-hour discussion-based exercises using a phased hypothetical scenario. To facilitate participation in Indiana, the health departments chose to divide participants into 3 tables with at least 1 state or local representative from each specialty area at each table. In Champaign-Urbana, they chose to divide participants in just 2 tables, one for the local health department folks and the other for state health department folks. The exercise was divided into 3 modules. Module 1 included a scenario and discussion questions to move through the initial health department preparedness and outbreak identification, including such topics as how the health department would confirm these are truly treatment failures due to resistance, and how they would manage these patients and what communication should be happening. Module 2, the response module, added content to the hypothetical scenario regarding what occurred over the next couple of weeks, and discussion questions guided thinking through topics such as what would trigger activation of the incident command structure, how could antibiotic susceptibility testing be conducted more broadly in the community to detect resistant GC, what information would be communicated to local providers and the public, and what roles would DIS play. Module 3, the recovery module, again added additional information to the hypothetical scenario and asked questions about how and when the health departments would scale back activities and evaluate the response, and what modifications were needed to their outbreak response plans. The day also included a debrief and written evaluation. Both pilots had 40 and 50 participants, and both included a few remote participants. Participants included state and local health department staff from STD programs and clinics, public health laboratories, emergency response and preparedness staff, agency leadership, and a couple of external partners. CDC staff served primarily as observers and included epi and lab staff from the Division of STD Prevention and the Center for Preparedness and Response. Overall, the tabletop exercise was a great success. We experienced strong collaboration and commitment within and across local and state health departments and CDC, and had high levels of attendance. Most participants attended the preparatory webinar and were engaged throughout the process. Evaluations overall described the event as well organized with useful discussions, and participants identified both tabletop exercise successes and opportunities for improvement. Through participating in the tabletop exercise, health department staff identified many opportunities to improve their outbreak response plans. And in fact, both states' health departments have already modified their plans to address many of the identified needs I'll describe now. Identified gaps included the need to clarify what constitutes a suspect or probable ARGC case and what response level was needed to address different outbreak levels. So for example, while a syphilis outbreak might be defined when syphilis picks up significant increase in cases, for ARGC, identifying one or just a couple of cases could require coordinated action and may require engaging the incident command structure. The exercise also pointed out to the need for clearer protocols and infrastructure on how providers report cases of suspected treatment failures. For example, should the jurisdiction investigate reported repeat positive GC tests within 30 days to identify possible treatment failures? Should there be a specific place providers call to discuss possible treatment failures and a defined protocol for what information the health department collects to determine if a case is a drug-resistant treatment failure? It also became clear through the TTX that more guidance was needed in the outbreak response plan regarding clinical management of suspected treatment failure cases. For example, when do you retreat? When do you use alternative therapies, including multi-day IV therapies? And how and where could patients receive such IV therapy, and who would pay for it if the patients were uninsured? There were also discussions about clarifying when and how to conduct and track tests of cure during an outbreak. There was a lot of discussion about how to facilitate access to timely GC culture and antibiotic susceptibility testing. Indianapolis already had much of this infrastructure in place through their participation in GISP and SURGE, but Illinois did not, and this was a real stumbling block for them in terms of how to assess antibiotic susceptibility during an outbreak. The Illinois Department of Public Health subsequently has already explored different ways to address the gap, including building culture and AST capacity in their own state public health lab, as well as piloting sending specimens or isolates directly to CDC for susceptibility testing. Other identified potential needs included the possibility of setting up MOUs with laboratories and hospitals in advance of an outbreak to facilitate engaging non-public health labs for expanding culture and antibiotic susceptibility testing, or hospitals for expanding testing or IV treatment. The tabletop exercise also identified the need for more developed communication materials and dissemination plans during an outbreak, some of which could be developed in advance, such as key messages to providers and the public based on different outbreak scenarios. Tabletop exercise discussions also identified needs for clearer articulation of local and state communication and responsibilities, particularly for when an outbreak is large or crosses over multiple jurisdictions. For example, does a large outbreak change which agency leads the response efforts? And lastly, there was also some discussion about defining thresholds for changing treatment and test of cure recommendations locally, even if they don't get changed nationally. As anticipated, the TTX also helped CDC identify a number of opportunities to improve how we prepare for ARGC outbreaks at the national level, including how we can better support jurisdictions. For example, seeing where local outbreak response plans succeeded and where gaps still existed will inform our efforts to improve and finalize CDC's ARGC Outbreak Response Plan Guidance document for jurisdictions. We also identified a number of ways we can improve CDC's internal ARGC Outbreak Response Plan, which actually which was last updated in 2012. The TTX pilots are also helping CDC think about additional guidance and TA we may be able to provide to jurisdictions on conducting surveillance and investigating suspected cases of GC treatment failure, including how we can enhance our support for local or regional culture capacity, antibiotic susceptibility testing infrastructures, and even locally perform molecular surveillance to look for specific mutations associated with identified GC resistance. We've started some of this work, although COVID-19 has definitely slowed down our progress. We now intend to complete the Tabletop exercise toolkit by early 2021 in order to facilitate ARGC planning and implementation of ARGC tabletop exercises in other jurisdictions. We anticipate this toolkit will include the final versions of all of the materials I've discussed today, including CDC's ARGC Outbreak Response Plan guidance for jurisdictions, the Tabletop exercise planning guidance, a facilitator's guide, a participant situation manual, the pre-TTX ARGC webinar, as well as an evaluation form and sample after action report. And with that, I want to thank you for listening to my presentation. I also want to acknowledge and thank all of my co-authors, as well as all of the ARGC tabletop exercise participants from the 4 jurisdictions, and CDC. My Q&A session is scheduled for Monday, September 21st from 4 to 4:30. And otherwise, please reach out to me if you have questions or comments. Thank you so much for your time.
Good day. Hello, everyone. My name is Ashar Azhar, and I'm affiliated with Louisiana State University Health Sciences Center in New Orleans, Louisiana, in the Department of Medicine, Section of Infectious Diseases. Today, I'm going to be talking about overuse of ceftriaxone for syndromic management of urethritis in men. Background. Antibiotic resistance is related to overuse of antibiotics. Ceftriaxone is the final effective class of antibiotics for Neisseria gonorrhea, and resistant strains have emerged. Urethritis is a common diagnosis in men at public health clinics. Syndrome of male urethritis studies have shown urethral discharge being the most common symptom. In public health clinics and other healthcare facilities, urethritis is treated using syndromic management with both ceftriaxone and azithromycin. However, most will test negative for NG, and the use of ceftriaxone could have been avoided. So the aim of our study was to identify urethritis cases treated with both ceftriaxone and azithromycin in Louisiana public health clinics. Compare to urethral discharge description, NG test results, and treatment. The goal was to explore the use of urethral discharge characteristics as a means to target ceftriaxone use. Methods. A retrospective chart review was conducted to identify urethritis cases between July 1, 2018 to December 31, 2018. The following data was collected: age, diagnosis of urethritis, discharge characteristics, NG test results, and treatment. ICD-10 codes were used to identify urethritis cases. Data was analyzed using SPSS. The following ICD-10 codes were used: R36.0, urethral discharge without blood; R36.9, urethral discharge unspecified; Z00.01, general adult medical examination with abnormal finding. Abnormal finding was considered as men with urethral discharge. Results. So total 707 charts for men with urethritis were reviewed. Out of those 707 charts, only 28% of men were NG positive, while 72% were NG negative that did not require actually ceftriaxone. Out of the 707 charts, 525 had complete data that formed the sample of this study. The mean age was 30 years, ranging from 14 to 74 years. So this is the results of the total 525 men that had the complete data. On this column, you can see the discharge consistency divided into thin, thick, some were missing. In this column is the discharge color divided into clear, yellow, green, greenish, yellow, and white. This is a column with treated men. This is a column with Ng positive, and this is a percentage on this column. I would like everyone to focus on the following points. Total men that were treated that had thin and clear discharge were 243. Out of those 243, only 28 men were Ng positive, meaning 12% only. While men that had thick and some color to the discharge were 148. And out of those 148 treated men, 80 were Ng positive, 54% were Ng positive. So out of the total 525 men, 148 were Ng positive, meaning only 28% were Ng positive, and 72% actually were Ng negative that did not require ceftriaxone. So our conclusions were ceftriaxone was unnecessary in almost 3/4 of men who received it. Thick discharge with color was associated with more positive Ng results compared to thin, clear discharge. Our data demonstrated that syndromic management of urethritis resulted in substantial overuse of ceftriaxone. Based upon these data, the Louisiana Department of Health Nurses STD standing orders have been revised to decrease overuse of ceftriaxone. I would like to acknowledge Professor Dr. Taylor for her mentorship, and I would like to thank Dr. Raman and Mr. Leggett for the substantial help in this project. This was not possible without their help. And I would like to thank everyone for their interest in this topic, and thank you for listening to my presentation. This is my email address, and I would like to answer any questions if you have any questions. Thank you very much again for listening to my presentation. Thank you.
Hi, I am Jamie Licklider, and on behalf of my co-authors, I will be presenting STD and HIV clinical services offered at safety net clinics in ending the HIV epidemic, or EHE, versus non-EHE counties. We know that timely, appropriate STD and HIV clinical services are important to curb transmission of these infections. It is important because timely access to care can increase the speed of obtaining needed services, thereby decreasing infectiousness. This year, CDC released the recommendations for providing quality STD clinical services. The recommendations outline key services that should be provided in different clinical settings. Even subsequent to the Affordable Care Act, it is also important to maintain STD and HIV safety net services. In addition to financial considerations, safety net providers may serve an important role in the provision of confidential, high-quality, same-day STD and HIV services. The United States has launched the Ending the HIV Epidemic, or EHE, initiative. In part, the EHE initiative seeks to increase HIV screening and PrEP uptake in select counties, including at clinics that provide specialty STD services. EHE is focused on areas with the most frequent HIV transmission, including counties and some rural states, as shown in blue on the map. Therefore, it is important to examine the extent of STD and HIV safety net services, both to enhance STD and HIV prevention efforts and to serve as a baseline to assess the impact of EHE funds. We examined key STD and HIV services offered by the primary STD safety net clinic in EHE and non-EHE counties as reported by local health departments, or LHDs. To select our sample of LHDs, first we identified 51 areas with the highest combined cases and rates of reported STD in 2015. All were included in the sample. Then we drew a random sample from the remaining LHDs for a total sample size of 668. A random sample was stratified by US Census region and jurisdiction population size with an oversample of the largest jurisdictions. We sent a web-based survey to the primary STD contact, or if there wasn't one, the local health official in the LHD. We collected data from March to May 2018. The survey covered a variety of topics. The following measures were included in this particular analysis. First, we assessed the availability of safety net services in safety net clinics that included clinics such as general public health clinics, federally qualified health centers, and STD clinics, just to name a few. For those who had such services in their jurisdiction, we asked them if the primary clinic that provided safety net STD services offered same-day services. Next, we assessed STD and HIV services offered by the primary safety net clinics with a focus on point-of-care testing, laboratory, PrEP, and NPEP services. 326 LHDs responded to the survey for a response rate of 49%. We weighted all analyses so LHDs were representative of LHDs in the United States. Our analytic sample was 240, and that was the LHDs who had a clinic in their jurisdiction who provided safety net STD services. 83 of these LHDs were in EHE counties. So next I want to focus on a few key results. As I mentioned earlier, timely access to services are important for preventing disease transmission. On the left side of this slide are findings for access to same-day services. EHE jurisdictions, which are the blue bars, had significantly higher reports of same-day services than non-EHE jurisdictions, which are the green bars. However, it's worth noting that even in EHE jurisdictions, 21% of the primary STD safety net clinics did not offer this service. On the right side of the slide are findings for HIV testing. 100% of clinics in EHE jurisdictions offered this service, and 91% in non-EHEs did so as well, and there are no significant differences. We also looked at 2 point-of-care STD tests in the primary safety net clinics. Syphilis RPR, which is on the left side of the slide, and on-site gonococcal urethritis testing, which is on the right side of the slide. For on-site RPR, 26% of primary STD safety net clinics in EHE jurisdictions and 20% in non-EHE jurisdictions reported offering RPR, and there were no significant differences here. For on-site gonococcal urethritis testing, only 19% of clinics in EHE jurisdictions and 20% in non-EHE jurisdictions reported offering this. And again, this was not significantly different between the two. We also assessed the availability of gonorrhea culture, which is on the left side of the slide, and extragenital chlamydia and gonorrhea testing, which is on the right side of the slide. Gonorrhea culture was available in about half of primary safety net, STD safety net clinics in both EHE and non-EHE jurisdictions. Extragenital chlamydia and gonorrhea testing was more commonly available, with 65% of clinics in EHE jurisdictions and 71% in non-EHE jurisdictions offering this service. Finally, we examined both PrEP and NPEP services in the primary safety net clinics that identified as STD clinic or combined STD and family planning clinics only. We found no significant differences between jurisdiction type. PrEP risk assessment and education were offered by 34% of STD clinics in EHEs and 45% of STD clinics in non-EHEs. PrEP referral was offered by 46% of STD clinics in EHEs and 55% of STD clinics in non-EHEs. However, PrEP initiation, full service PrEP, and NPEP were only offered by a smaller minority of STD clinics in both EHE and non-EHE jurisdictions. In general, our results did not highlight much difference in STD and HIV services offered by the primary STD safety net clinic by EIG status. However, our results do suggest that the current availability of key STD and HIV clinical services is not sufficient to meet STD or HIV prevention goals. Only HIV testing was widely available. Although the majority of clinics did offer same-day services and extragenital chlamydia and gonorrhea testing, there was still room for improvement in the provision of both services. However, point-of-care STD testing and many PrEP and NPEP services were lacking in a majority of primary safety net clinics that offer STD services. Without an expansion of resources, LHDs might explore collaborations with healthcare systems and innovations in testing to expand needed STD and HIV services. Thank you for your time today.
Good morning, and thank you for the invitation. Today I will be speaking about epidemiologic treatment of contacts to gonorrhea and chlamydia infection in STD clinic patients in Seattle, Washington. Epidemiologic treatment, or epi-treatment, is the practice of treating sex partners of persons with bacterial STIs before confirmation of infection. For many years, epi-treatment has been a mainstay of STI prevention and is often justified by the high prevalence of infection in partners and a concern that waiting for STI test results will result in delayed or missed opportunities for treatment, leading to further transmission or reinfection of the primary partner. Epi-treatment evolved in an era of abundant antibiotics and diagnostics with poor sensitivity, but advances in molecular diagnostics and increasing awareness of the importance of extragenital testing now allows us to detect virtually all infections. More urgently, antibiotic resistance has become a critical public health concern. We know that exposure to antibiotics promotes antibiotic resistance, and the use of antibiotics for epi-treatment may be contributing to the rise of antimicrobial resistant gonorrhea. For this study, we sought to quantify the extent to which epidemiologic treatment is provided to a population at high risk of STIs and the proportion of episodes of epidemiologic treatment that occurs in the absence of an infection using 25 years of clinical visits to the Public Health Seattle and King County Sexual Health Clinic in Seattle, Washington. We considered the reason for a patient's visit as evaluation for contact to gonorrhea and/or chlamydia if the patient reported contact to either of these infections during their intake risk assessment or their clinical exam. In some cases, patients did not report gonorrhea and/or chlamydia contact, but were deemed to be a contact by clinicians as a result of communication from disease intervention specialists co-located within the STD clinic. Patients who reported STI symptoms, or for whom clinicians recorded signs or symptoms, were excluded as these patients were likely to have received syndromic treatment. We abstracted treatment prescribed from the medical record associated with the contact to gonorrhea and/or chlamydia visit. Per clinic policy, patients treated with an anti-gonorrheal and anti-chlamydial antimicrobial were considered epi-treated for gonorrhea, and patients who received an anti-chlamydial agent were considered epi-treated for chlamydia. We also abstracted gonorrhea and/or chlamydia tests performed for the contact to gonorrhea and/or chlamydia visit, stratified by anatomic site of test for men who have sex with men. We considered treated persons who were negative for gonorrhea and/or chlamydia at all tested anatomic sites as overtreated. It is also important to note that due to inconsistencies in recording gender identity during the study period, gender presented may not reflect patients' gender identity or biological sex. We then used the Cochrane-Armitage test for trend to assess for significant differences in the proportion of these patients who had a clinic visit or contact to one of these bacterial STIs, who were tested, treated, and overtreated across five-year periods from 1994 to 2018. From 1994 to 2018, there was a significant increase in the number of asymptomatic clinic attendees evaluated for contact with gonorrhea and/or chlamydia, evaluated persons who received epi-treatment, epi-treated persons who were tested at least one anatomic site, and the proportion of treated and tested persons who were overtreated. The proportion of treated and tested persons who were overtreated did decrease from 80% in 1994 to 1998 to 66% in 2014 to 2018. However, the number of persons overtreated increased substantially. In the most recent 5-year period of 2014 to 2018 alone, nearly 2,000 persons were overtreated for gonorrhea and/or chlamydia. Since 2009, the majority of contacts to gonorrhea and/or chlamydia who were overtreated were men who have sex with men. This shift in risk group could partially be explained by both a change in the clinic's patient population, which at this point is mostly men who have sex with men, and increasing gonorrhea morbidity within the MSM population. Among MSM contacts to gonorrhea and/or chlamydia, most were tested for urethral infections prior to 2009, after which the most commonly tested site was the pharynx. Rectal testing steadily increased over the entire examined time period. However, gonorrhea and chlamydia positivity at tested anatomic sites has not changed significantly over the time period examined, with the exception of pharyngeal infections. About 30% of MSM contacts to gonorrhea and/or chlamydia tested positive at the rectum over all periods, while the proportion positive of those tested at the pharynx increased from 12% in 1994 to 1998 to 17% in 2014 to 2018. And relatively few urethral infections were detected in MSM at that site across all periods examined. These results may point to the relative importance of asymptomatic extragenital infections in gonorrhea and chlamydia transmission, though the clinical implications for those infected remain unclear. A commonly cited reason for the continuation of EPI treatment as a public health practice is that infected patients will not return to the clinic for treatment and may transmit the bacterium in the interim period. However, we found that over 90% of patients who screened positive for gonorrhea, meaning they came to the clinic for a test without any symptoms or not for a contact to one of these infections, did return to the clinic for treatment within a median of 7 days. In summary, both the number and proportion of STD clinic visits for contact with gonorrhea and/or chlamydia in the Seattle-King County Sexual Health Clinic have increased significantly over the past 25 years, with nearly 2,000 episodes of EPI treatment in the last 5 years alone. Most of this increase occurred among MSM and is consistent with changing demographics of the clinic's main patient population. At the same time, the proportion of contacts to gonorrhea and/or chlamydia who received epidemiologic treatment and tested positive has remained under 35%. Together, these trends demonstrate that a substantial number of STD clinic patients received antimicrobial therapy in the absence of an infection. One limitation of this analysis is the fact that men who have sex with women exclusively and females were less frequently screened for extragenital infections, which may have incorrectly classified patients with extragenital infections in the absence of urethral or cervicovaginal infections as negative, and potentially underestimated positivity in these populations. Additionally, we considered all patients who self-reported contact chlamydia and/or gonorrhea as contacts to these infections. It's possible that patients may not have accurately reported their sexual exposures, leading to an under or overestimate of these contact visits. However, patients were explicitly asked whether this was the reason for their visit each time they presented to the clinic via standardized intake form or clinician-led interview. The temporal trend of increased positivity among EPI-treated contacts may be due to the adoption of more highly sensitive NAT testing over the periods examined. Finally, given that the majority of our patient population is white men who have sex with men, it is possible that our results may not be generalizable to clinics serving a higher proportion of racial minorities and heterosexuals. We must seriously consider that any benefits of EPI treatment may be outweighed by the potential for development of antibiotic resistance. Azithromycin reduced susceptibility among MSM is over 8% nationally compared to only 2% among heterosexual men. This may be due to the recent increase in overuse of azithromycin as part of EPI treatment for MSM, as prior azithromycin use has been associated with a twofold increase in minimal inhibitory concentration. At the same time, rates of STDs continue to increase among MSM. Exposure to more sexual partners with a lower condom use rate in sexual networks with higher prevalence of bacterial STIs will result in more frequent exposure to these infections and thus antibiotic exposure through EPI treatment, which may further drive antimicrobial resistant gonorrhea. Given the current epidemiologic context, a closer examination and quantification of the benefits and risks of epi treatment is warranted, particularly among MSM. More data on the rates of return for treatment from more diverse settings is needed. One potential alternative that could be explored is shared treatment decisions, where clinicians and patients together decide whether epi treatment or waiting for results is the better option for treatment. Thank you very much. I look forward to hearing your feedback and questions.
Hello, my name is Diana Tordoff. I want to thank the conference organizers for inviting me to present our research. I want to begin by acknowledging my privileges as a cisgender researcher and that this is a limitation of the present analysis. Reporting on transgender and non-binary identities in HIV and STI surveillance in the US is suboptimal and inconsistent across jurisdictions. As of 2015, 16 public health jurisdictions separately reported HIV surveillance data for transgender men and women, compared to only 4 jurisdictions for STI surveillance. For trans populations, accurately reporting on STIs requires using validated questions to collect gender identity data, such as the two-step method, that also include non-binary and write-in options. It also necessitates asking trans-inclusive questions about sexual behavior, symptoms, and anatomy. This includes asking questions that determine the anatomic sites of exposure based on an individual's current anatomy and sexual behavior. There is variation in the proportion of trans and non-binary people who desire to have or have had a range of surgical procedures. Here, we focus on procedures relevant to STIs. According to data from the 2015 US Transgender Survey, the dark blue color shows few trans women have had a vaginoplasty or orchiectomy, and few trans men have had a hysterectomy, metoidioplasty, or phalloplasty. And these numbers are lower for non-binary people. Over the past 4 years, the Sexual Health Clinic in Seattle has implemented a series of more trans-inclusive questions into the clinic's intake questionnaire. In May 2016, the clinic switched to using a validated two-step question for ascertaining gender identity. At this time, trans patients received a paper form they could complete on their own or with a clinician about their anatomy, symptoms, and sexual partners and behaviors. However, fewer than half of trans patients completed the paper form. Then in December 2018, in response to the trans community's request that clinic procedures be the same for cisgender and trans patients, trans-inclusive questions were developed for the computer-assisted self-interview questionnaire that replaced the paper form. This allowed for consistent data collection about symptoms and exposures for both trans and cisgender patients. For this presentation, we aim to assess the acceptability and consistency of responses to these new questions. I'll provide a brief overview of the survey methods. All English-speaking patients with a new problem visit complete a self-administered computerized intake survey. All patients are asked about their gender identity, sex assigned at birth, and pronouns. Transgender and non-binary patients are then asked a set of questions about their current anatomy, previous surgical procedures, and current hormone use. Lastly, all patients are asked questions about sexual behavior, exposures, and symptoms. For trans patients, we use conditional branching logic based on their sex assigned at birth and reported surgeries to ask the relevant questions. For cisgender patients, logic is based only on their sex assigned at birth. For this presentation, we focus on this set of questions. We ask a check all apply question to determine what anatomy a person currently has, as well as their previous surgical procedures. We also ask questions about their current hormone use. These are framed as being relevant to clinical care for STIs. And notably, we do not ask about top surgeries, such as mastectomy or breast augmentation, or facial surgeries, since they are not relevant to care. We include all trans and non-binary patient visits at the Sexual Health Clinic between December 2018 and December 2019. Throughout the presentation, we use the abbreviation AMAB for people who are assigned male at birth and AFAB for people who are assigned female at birth. We use the response rate as a proxy measure for the acceptability of each of these questions. And we also determine the consistency of responses between anatomy and surgery questions. I want to make a brief remark about language. Terminology used in survey and instrument evaluation, such as validity, completeness, consistency, are all terms that have historically been used to construct transgender people as other or non-normative. And specifically when talking about genitalia, these terms are used to imply that transgender bodies are incomplete or misaligned. These terms have also been used to deny the authenticity of trans people's gender via discriminatory policies, such as requiring proof of surgery before allowing people to change their gender marker on government IDs. In this analysis, we use the word consistent to describe the consistency of responses, and not to imply that certain bodies or genitalia are more or less valid or complete. Lastly, because the CASI does not identify intersex people, this analysis assumes typical sexual differentiation and development of genitalia and gonads. We acknowledge this as a limitation of our current analysis. During the study period, 184 unique patients attended 280 clinic visits. 24% were trans women, 13% were trans men, 44% were non-binary people assigned male at birth, and 19% were non-binary people assigned female at birth. 55% of patients were white. For response rates, we saw that 90% of patients responded to anatomy questions. 7% indicated that they preferred to discuss their anatomy with their provider, and 3% did not respond. In addition, 83% of patients responded to surgery questions and 95% responded to hormone questions. We observed that non-response differed by gender. Non-binary patients were much more likely to answer questions about anatomy. And non-binary patients assigned male at birth were most likely to answer questions about prior surgeries. The majority, 94% of patients reported having no surgeries. The most commonly reported procedures was hysterectomy, followed by oophorectomy and orchiectomy, and only one transgender woman reported a vaginoplasty. Current hormone use also varied by gender. Trans women and men were more likely to report any hormone use, shown by the purple bars, compared to non-binary patients. Next, we examined the consistency of responses between anatomy and surgery questions. Here we stratify based on whether or not the patient reported any surgical procedures. We saw that patients who report one or more surgeries were more likely to have consistent responses compared to patients who reported no surgeries. Among patients with no reported surgeries, having consistent responses meant indicating having a vagina, cervix, uterus, and ovaries, or indicating having a penis, prostate, and testicles from the check all that apply anatomy question. Alternatively, patients could have reported an anatomy that was consistent with their reported surgeries. For example, a trans woman reported having an orchiectomy and vaginoplasty, and also indicated having a vagina and a prostate on the anatomy question. Another example is that several trans men reported having an oophorectomy and hysterectomy, and also indicated having a vagina, but no uterus, cervix, or ovaries on the anatomy question. Approximately 1/3 of patients partially identified their anatomy. For example, some trans men reported no surgeries and marked having a vagina, but did not indicate having a cervix, ovaries, or uterus. Or trans women who reported no surgeries, but indicated having a penis and did not indicate having testes or a prostate. Lastly, 5 patients used gender-affirming terms to describe their anatomy instead of biomedical terminology. For example, several trans men who reported no surgeries indicated having a penis or phallus and no other anatomy. This is consistent with language used by many trans people to talk about their bodies. In conclusion, our findings demonstrate the feasibility of implementing trans-inclusive questions at a sexual health clinic that serves both cisgender and transgender patients. There is an 80% or higher response rate to anatomy and surgery questions, suggesting they are reasonably acceptable but may have room for improvement. Questions about genital surgeries may be more useful for use in skip patterns and conditional logic than check all that apply anatomy questions, since many patients partially identified anatomy. This analysis also had several limitations. Inconsistent responses may be in part due to the use of high-level medical terminology and the check all that apply format. And as previously mentioned, this analysis assumes typical sexual differentiation and development of gonads and genitalia. In addition, the current survey relies on biomedical terms as it does not facilitate linguistic self-determination or incorporate gender-affirming language options. Recent research has demonstrated the importance of trans-inclusive language when talking about sexual behaviors and anatomy. A notable example is Dr. Obidin Malver at UCSF, who recently developed a customizable survey that allows trans patients to determine what words are used to refer to their anatomy. For next steps, I will be presenting tomorrow on how these new questions have allowed us to evaluate anatomic site-specific testing and screening among trans patients. And we also plan to examine patterns of contraception use, pregnancy histories, and OBGYN healthcare utilization amongst trans patients assigned female at birth. Lastly, we hope to conduct qualitative research and continue community engagement to further improve data collection and clinical care for trans and non-binary patients. Lastly, I would like to thank the patients who attended the STD clinic and my mentor, Lindley Barbie, and my co-authors. Thank you.